Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Hey DIA students, we are completing daily 2 to 3 MCQ session of different topics. In this session, we will explore disorders affecting the outer, middle, and inner ear that impact both hearing and balance. Conditions such as otitis media, hearing loss, Meniere's disease, and ear trauma can significantly affect a client's quality of life if not addressed promptly. As nurses, our role includes early recognition of symptoms like pain, discharge, tinnitus, or vertigo, administering appropriate treatments, preventing complications, and teaching clients protective measures for ear health. By mastering these concepts, you will be better prepared to deliver safe, effective care and succeed in NCLEX-style questions related to ear disorders. See this for a few seconds. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exam successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy to watch. Recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, eBooks, and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail during comprehensive lecture. This isn't just another review. It's everything you need in one. Please scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get. Let us now move into another high-level NCLEX practice question to sharpen your reasoning. During an admission interview, a nurse notices that the client repeatedly asks for questions to be repeated. The nurse suspects possible occupationally related hearing loss. Based on the client's occupational history, which profession places the client at the highest risk for developing sensorineural hearing loss due to chronic exposure to hazardous noise levels? Here are the options to consider. Option 1, telephone operator. Option 2, computer programmer. Option 3, musician. And option 4, teacher. The correct answer is option 3, musician. The reason this option is correct is that musicians, particularly those who are exposed to prolonged, repeated, and unprotected exposure to loud instruments, amplifiers, and concert environments, are at high risk for noise-induced sensorineural hearing loss. This condition occurs when hair cells within the cochlea are permanently damaged by noise levels greater than 85 decibels. Unlike conductive hearing loss, which results from outer or middle ear issues and can sometimes be reversible, sensorineural loss is permanent. Early signs include tinnitus or ringing in the ears, difficulty understanding speech in noisy areas, and gradual loss of high-frequency sounds. Preventive measures involve the use of specialized earplugs, limiting exposure time, and undergoing regular audiometric screenings. Now looking at the first incorrect option, a telephone operator may wear headsets for many hours, but these do not reach hazardous decibel levels. The discomfort experience is generally temporary and does not lead to permanent auditory injury. Turning next to the second incorrect option, computer programmers are engaged in sedentary, screen-based work. While they may develop problems like eye strain or repetitive musculoskeletal injuries, hearing loss is not associated with this field. Finally, considering the fourth incorrect option, teachers certainly work in noisy classroom environments, but the sound intensity is not typically high enough to cause permanent auditory damage. Instead, teachers are more prone to conditions like voice strain or laryngitis due to constant speaking. From a broader clinical perspective, prolonged noise exposure irreversibly damages the sensory hair cells in the cochlea. Once these cells are lost, they do not regenerate, which makes early prevention critical. Occupations at risk include not only musicians but also construction workers, military personnel, factory staff, and airport ground crews. For assessment, red flags include a client frequently asking for repetition, reporting tinnitus, and experiencing difficulty hearing in crowded environments. As nurses, it is our role to assess occupational exposure, provide education about protective measures, and ensure appropriate referrals to audiologists or otolaryngologists. And here is your Stan Coast Pearl. Think of the cochlea as a delicate piano. Once the high notes are damaged by relentless loud noise, they can never be retuned. This is why musicians and other high-decibel workers face the greatest risk of irreversible sensorineural hearing loss. All right, let us smoothly transition into another practice scenario that will sharpen your NCLEX reasoning skills. While performing an ear examination, the nurse observes that the client has a large amount of cerumen in the external auditory canal. The client asks for advice about the safest way to clean their ears at home. Now, let us explore the options. Option 1 says, it is best to use the corner of a soapy washcloth to clean the outer ear. Option 2 asks, do you prefer a short or long cotton-tipped applicator? Option 3 suggests, have you ever tried removing earwax with a hairpin? And finally, option 4 offers, I can refer you to a physician who will clean them. The correct answer here is option 1. It is best to use the corner of a soapy washcloth to clean the outer ear. This is the safest response because cerumen plays an important protective role. It is produced by ceruminous glands and serves as a natural barrier, lubricator, and antimicrobial agent for the ear canal. It prevents bacteria, fungi, and dust from entering while helping to maintain an acidic environment that discourages infections. The key fact is that earwax naturally migrates outward, helped by jaw movements and shedding of epithelial cells, so routine cleaning inside the canal is unnecessary. Using a damp, soapy washcloth on the outer ear maintains hygiene without risking injury to delicate canal tissue or the tympanic membrane. On the other hand, option 2, which recommends cotton-tipped applicators, is not appropriate. Instead of cleaning, cotton swabs often push cerumen deeper, causing impaction and even conductive hearing loss. They can also scrape and damage the canal skin, leading to painful otitis externa, or in severe cases, puncture the tympanic membrane. That is why clients should be educated using the classic phrase, never put anything smaller than your elbow in your ear. Moving to option 3, the suggestion of using a hairpin is highly unsafe. Foreign sharp objects like hairpins, pens, or safety pins can easily cause trauma, lacerations, bleeding, or perforation of the tympanic membrane. Such practices are one of the leading causes of emergency visits related to ear injuries. Moreover, they introduce infection risks and can result in permanent hearing loss. This makes it the most dangerous choice of all. Finally, option 4, which offers referral to a physician, is not the best response for a normal finding. While referral is certainly appropriate if cerumen is hard, impacted, or symptomatic, causing hearing loss, vertigo, tinnitus, or pain, it is not necessary for routine, normal earwax accumulation. Over-referring can burden clients with unnecessary medical costs and interventions when simple hygiene measures suffice. Here are the key clinical insights to carry forward. First, cerumen is beneficial. It protects, lubricates, and provides antimicrobial defense. Second, safe practices involve cleaning only the outer ear gently with a damp cloth, leaving the canal alone. Third, unsafe practices include cotton swabs, sharp objects, or even ear candling, all of which can harm the ear. And lastly, referral is warranted only in cases of impaction or symptomatic buildup. For your NCLEX tip, always prioritize safety. If an option involves inserting any object into the ear canal, it is unsafe. Remember, the safest answer is usually the one that prevents harm. And here is a Stan Coast Pearl to lock this concept in. Think of cerumen as the ear's natural moisturizer and shield. The safest advice is to clean only what you can see, never venture inside the canal. Let us now smoothly move into another NCLEX practice scenario that focuses on auditory assessment during a routine examination. A nurse is preparing to assess a client's auditory function. Which instrument is most appropriate to evaluate conductive versus sensorineural hearing loss using standardized bedside tests? Here are the options to consider. Option 1 is an otoscope. Option 2 is a tuning fork. Option 3 is a reflex hammer. And option 4 is a stethoscope. The correct answer is option 2, the tuning fork. When we think about why this is correct, remember that the tuning fork is the primary bedside instrument used to distinguish between conductive and sensorineural hearing loss. Two simple but powerful tests are involved. First, the Weber test. The tuning fork is struck and placed on the midline of the skull, often the forehead. If sound is louder in the affected ear, it suggests conductive hearing loss, while louder in the unaffected ear points to sensorineural loss. Second, the Rinne test. The tuning fork is placed first on the mastoid bone for bone conduction, then near the ear canal for air conduction. Normally, air conduction is greater than bone conduction, but in conductive loss, bone conduction is equal or greater, whereas in sensorineural loss, both are diminished, yet air conduction remains longer than bone. These two tests together give a quick, non-invasive way to localize the problem and guide further diagnostics like audiometry. Now, why are the other options incorrect? An otoscope, option 1, allows visualization of the external canal and tympanic membrane to detect things like cerumen impaction, perforation, or infection, but it cannot directly assess hearing acuity. A reflex hammer, option 3, is designed to elicit deep tendon reflexes to check neuromuscular and spinal cord function, not hearing. Finally, the stethoscope, option 4, is used for auscultating heart, lung, and bowel sounds. It is excellent for internal body sounds, but not for evaluating hearing loss types. Clinically, it is important to recall that conductive hearing loss originates in the outer or middle ear from causes such as cerumen impaction, otitis media, or otosclerosis, while sensorineural hearing loss involves the inner ear, cochlea, or auditory nerve, often from aging, presbycusis, chronic noise exposure, Meniere's disease, or ototoxic drugs such as aminoglycosides. Mixed hearing loss combines both types. Identifying the category early is critical since untreated hearing impairment can affect communication, safety, and overall quality of life. Here is your Stand-Coast Pearl. Think of the tuning fork as the hearing detective. The Weber test tells you where the sound localizes, while the Rinne test tells you how the ear conducts it. Together, they reveal whether the issue lies in the sound pathway, meaning conductive loss, or in the nerve, meaning sensorineural loss. This memory trick can anchor your understanding when answering NCLEX questions on auditory assessment. Let us continue building your NCLEX-style script with a smooth narration that keeps learners engaged. Imagine this scenario. A client comes to the clinic complaining of a persistent ringing and buzzing sound in both ears, which seems to worsen in quiet environments. The nurse quickly recognizes this as tinnitus and must decide on the most important follow-up question to identify a possible medication-related cause. Here are the options to consider. Option 1 asks, what childhood illnesses, such as measles or mumps, have you had? Option 2 inquires, what type of work or occupational noise exposure do you currently have? Option 3 questions, how would you describe your typical daily diet? And option 4 focuses on, how often and how much aspirin or other salicylates do you take? The correct answer is option 4. How often and how much aspirin or other salicylates do you take? This is correct because tinnitus is a classic early sign of salicylate toxicity, also known as salicylism. When aspirin or similar drugs are taken in high or repeated doses, they can damage the delicate cochlear hair cells and alter auditory nerve conduction, producing ringing or buzzing in the ears. If left unchecked, the condition may progress to hearing loss, dizziness, nausea, vomiting, metabolic acidosis, and even life-threatening complications. By asking directly about aspirin intake, the nurse can quickly establish a likely cause and effect relationship, intervene early to prevent permanent ototoxicity, and collaborate with the healthcare provider to adjust or discontinue the medication. Turning now to option 1. What childhood illnesses, such as measles or mumps, have you had? While this may provide historical insight, it is not the priority here. Childhood illnesses can cause permanent sensorineural hearing loss, but they are not responsible for acute or reversible tinnitus like aspirin. Toxicity is. Looking at option 2. What type of work or occupational noise exposure do you currently have? While occupational noise exposure is indeed a common cause of tinnitus and long-term hearing loss, it is not the most urgent or likely cause in this situation. Since aspirin use can be stopped immediately to reverse symptoms, medication assessment takes priority over environmental history. Finally, option 3. How would you describe your typical daily diet? This is the least relevant of all. While poor nutrition can occasionally affect neurological or vascular health, it is not recognized as a typical cause of tinnitus. Asking this would not help the nurse identify a modifiable, urgent factor in this case. To reinforce your learning, here are some clinical insights. Tinnitus is defined as the perception of sound, such as ringing, buzzing, or humming, without any external stimulus. Major causes include ototoxic medications like salicylates, aminoglycosides, loop diuretics, and some chemotherapies. Prolonged noise exposure, presbycusis, which is age-related sensorineural loss, and conditions like Meniere's disease or vascular abnormalities. The nurse's role is to rapidly identify medication-induced tinnitus, document severity and duration, and report it promptly to prevent permanent damage. A key point is that aspirin-induced tinnitus is usually reversible if detected early. Here is your NCLEX exam strategy. When you see a symptom that could be drug-related, prioritize assessing current medications before exploring non-modifiable or less urgent causes. Stand coast. Pearl. Remember A for aspirin and A for audible ringing. Whenever a client mentions tinnitus, the nurse should immediately think of aspirin use as a potential culprit. Let us move into this next NCLEX-style practice scenario with a clear and engaging flow. A client with bilateral sensorineural hearing loss is using a behind-the-ear hearing aid but reports frustration due to an intermittent, loud, shrill whistling noise, especially when engaging in conversations. The nurse recognizes this sound as acoustic feedback. The question asks, which nursing action would be most effective in reducing or eliminating this feedback? Here are the options to consider. Option 1 suggests repositioning the hearing aid within the ear. Option 2 recommends cleaning the hearing aid with a soft cloth. Option 3 involves replacing the battery in the hearing aid. And option 4 advises turning down the volume in the hearing aid. The correct answer is option 1. Repositioning the hearing aid within the ear. This is correct because feedback occurs when amplified sound leaks from the ear canal and re-enters the microphone, creating a loop of whistling noise. The most common cause is improper placement of the ear mold or a loose fit within the canal. By simply repositioning the device, the nurse ensures a snug fit, prevents sound leakage, and eliminates the feedback immediately. In addition, the nurse should assess for cerumen impaction since wax can deflect sound outward, making feedback worse. Teaching clients proper insertion techniques is therefore key to preventing this frustrating issue. Looking at the other choices, cleaning the hearing aid with a soft cloth, as in option 2, is indeed important for maintaining the device, but it does not resolve the actual acoustic loop that produces feedback. It removes debris, dirt, and earwax from the surface, but it does not stop the shrill sound. Option 3, replacing the battery, is also not the solution, because a weak battery causes reduced amplification or static, not feedback. Although battery care is part of good hearing aid management, it does not address the immediate whistling. Option 4, lowering the volume, may reduce the feedback temporarily, but it also diminishes sound quality for the client, making communication more difficult. It masks the symptom rather than fixing the problem. If repositioning does not resolve the issue, then the ear mold may need to be refitted or reprogrammed by an audiologist. Here are some clinical pearls for your NCLEX success. First, remember that feedback occurs when sound leaks and re-enters the microphone, creating a loop. The primary nursing action is to ensure proper placement and fit of the hearing aid. Contributing factors include cerumen impaction, loose ear molds, cracked tubing, and excessively high volume. Education should focus on correct insertion, daily cleaning, routine wax checks, and reporting persistent problems to an audiologist. And finally, here is your NCLEX tip. When faced with a question about whistling feedback, always think placement first. Stand coast. Pearl. Whistling means slipping. If a hearing aid whistles, your first step is always to check how snugly it fits in the ear canal before considering other adjustments. Let us smoothly transition into the next NCLEX-style question with a focus on pharmacology and sensory changes. A 64-year-old client recently reports experiencing diminished hearing acuity that has progressively worsened over the past several weeks. The nurse carefully reviews the client's medication list, which includes a non-steroidal anti-inflammatory drug prescribed for osteoarthritis, a beta-adrenergic blocker for hypertension, an aminoglycoside antibiotic for a recent urinary tract infection, and a histamine 2 receptor antagonist for gastroesophageal reflux disease. With this context in mind, the key question is, based on this medication history, which pharmacologic agent is most likely responsible for the client's hearing changes? Here are the options to consider. Option 1, a non-steroidal anti-inflammatory drug. Option 2, a beta-adrenergic blocker. Option 3, an aminoglycoside antibiotic. And option 4, a histamine 2 receptor antagonist. The correct answer is option 3, the aminoglycoside antibiotic. This is the right choice because aminoglycosides, such as gentamicin, tobramycin, and amikacin, are well-documented ototoxic drugs. They directly damage the delicate cochlear and vestibular hair cells in the inner ear, leading to manifestations such as tinnitus, a feeling of fullness in the ear, high-frequency hearing loss, or balance disturbances. The risk is further amplified in clients receiving high doses, prolonged courses, concurrent ototoxic drugs such as loop diuretics or vancomycin, and in those with impaired renal clearance. The underlying mechanism involves free radical formation that causes mitochondrial injury in cochlear hair cells. And unfortunately, once this damage occurs, it is permanent. Because aminoglycosides are also nephrotoxic, strict renal monitoring and frequent checking of serum peak and trough levels are critical to reduce toxicity risks. Looking at option 1, the non-steroidal anti-inflammatory drug, we know that drugs like aspirin, especially in higher doses, can cause reversible tinnitus or mild hearing changes due to altered cochlear blood flow. However, this effect is temporary, resolves after discontinuation, and does not typically cause the progressive permanent hearing loss seen with aminoglycosides. Shifting to option 2, the beta-adrenergic blocker. Medications like propranolol or metoprolol can sometimes cause dizziness or vertigo because of their influence on blood pressure and cardiac output, but they do not directly affect the auditory system and are not associated with ototoxicity. Therefore, they are not the culprit here. Finally, when we analyze option 4, the histamine 2 receptor antagonist, such as ranitidine or famotidine, their primary action is on gastric acid reduction. Their most common side effects include headache or confusion in older adults, but they have no link to auditory or vestibular damage. Hence, they are the least likely explanation for the client's hearing loss. Here is the Stan Coast Pearl to lock this concept into memory. Always treat aminoglycosides as a red flag whenever you see a client presenting with new hearing loss or balance problems. Unlike NSAID-related tinnitus, which is reversible, aminoglycoside-induced ototoxicity is permanent and irreversible. Early detection, renal function monitoring, and careful drug level checks are vital for preventing lifelong hearing damage. Now shifting into a clinical scenario on sensory nursing care, consider this. A nurse is preparing to instill prescribed Otic medication into the ear of a 45-year-old adult client with chronic otitis externa. To ensure proper absorption and effectiveness, which technique should the nurse use to straighten the client's external auditory canal before administering the drops? Here are the options. Option 1, pull the auricle upward and backward. Option 2, pull the auricle downward and forward. Option 3, pull the auricle upward and forward. Or, option 4, pull the auricle downward and backward. The correct answer is option 1, pull the auricle upward and backward. This is correct because in adults, the ear canal is about 2.5 centimeters long and shaped like an S-curve. Pulling the auricle upward and backward helps straighten this canal, ensuring that the medication flows all the way to the tympanic membrane without pooling in the outer portion. This technique reduces the risk of irritation, improves absorption, and allows better coating of the inner structures with the medication. Moving on to why the other choices are incorrect. Pulling the auricle downward and forward, as in option 2, is the right approach for infants under 3 years of age because their canals are shorter and more horizontal. Using this in an adult would leave the canal curved and block effective medication flow. Option 3, pulling the auricle upward and forward, is misleading because forward traction actually increases the canal's curvature, making it more difficult for drops to move inward. Option 4, pulling the auricle downward and backward, is another technique for young children but not adults. And if used in adults, it could trap medication in the outer ear and even increase the risk of ototoxicity if aminoglycosides are prescribed. To place this in clinical context, Remember that infants under 3 years need downward and backward pulling because of their shorter, more horizontal canal, while children over 3 years and adults always require upward and backward pulling. Additionally, nursing best practice includes warming eardrops to body temperature to prevent dizziness, positioning the client on the unaffected side for 5 to 10 minutes to encourage absorption, gently pressing the tragus to help distribute the drops, and loosely placing cotton in the outer ear if ordered without occluding the canal. Here is a simple NCLEX memory trick. Up for grown-ups, down for babies. This phrase helps you instantly recall that adults require upward and backward traction, while infants require downward and backward. And finally, the stand coast pearl. Correct ear positioning is more than a technique. It is directly tied to anatomy, client safety, and treatment success. Using the wrong method can lead to treatment failure or serious complications, particularly when ototoxic ear medications are involved. Let us move forward with another high-yield NCLEX practice question that sharpens your understanding of safe medication administration. A nurse administers prescribed Otic drops to an adult client diagnosed with chronic otitis externa. To maximize therapeutic absorption and ensure safe outcomes, which discharge teaching is most appropriate for the nurse to provide immediately after installation? Here are the choices. Option 1. Keep your head tilted toward the unaffected side for at least 5 minutes. Option 2. Pack a cotton ball tightly into the external ear canal to prevent leakage. Option 3. Avoid forceful nose blowing for at least 1 hour. And option 4. Wipe away any excess medication that drains from the outer ear. The correct answer is option 1. Keep your head tilted toward the unaffected side for at least 5 minutes. This intervention is essential because gravity allows the eardrops to flow downward, coating the canal lining and tympanic membrane. Maintaining this tilt for several minutes ensures maximum absorption, prevents early drainage, and helps the medication reach inflamed tissues deeply. This teaching is particularly vital in chronic otitis externa, where prolonged exposure of medication to affected areas speeds recovery. Sitting up too soon risks wasting the medication and results in incomplete treatment. Now let us carefully examine why the other options are not correct. Starting with option 2, tightly packing a cotton ball inside the ear canal is unsafe. It can create pressure, damage the delicate tissues of the external ear, and trap moisture, increasing the risk of fungal infection. At best, a cotton ball may be placed loosely at the entrance to absorb drainage, but it should never be packed tightly. Moving on to option 3, advising the client to avoid nose blowing for 1 hour is unrelated to routine eardrop installation. This advice is more appropriate after middle ear procedures, such as tympanoplasty, or when the eustachian tube is involved, not for external canal treatment. Lastly, option 4 suggests wiping away excess medication immediately. While hygiene is important, this is not the priority teaching. Wiping too soon may encourage the client to change position prematurely, allowing the drops to drain before full absorption. Cleaning should occur only after the 5-minute tilt has been maintained. Here is the clinical pearl for NCLEX. Always remember that positioning is the most crucial step in eardrop administration. Gravity ensures proper drug distribution, and evidence-based guidance recommends a 5-minute tilt for adults. Also, avoid any action that risks infection or tissue trauma, such as tightly packing cotton. As a practical tip, warming the eardrops in the hand before use prevents dizziness caused by cold solutions stimulating the vestibular system. Let us transition smoothly into this next high-yield NCLEX practice scenario. While inspecting a client's ear during a focused otoscopic examination, the nurse observes that the external auditory canal is red, swollen, and tender to touch, while the tympanic membrane remains intact without perforation. The question asks, based on these findings, which additional assessment result would most strongly support a diagnosis of acute otitis externa? Here are the possible choices. The first option is foul-smelling purulent drainage from the ear canal. The second option is the presence of a scarred or opaque tympanic membrane. The third option is a subjective report of diminished hearing acuity. And the fourth option is palpable preauricular and postauricular lymphadenopathy. The correct answer is option 1, foul-smelling purulent drainage from the ear canal. This finding is the most specific and confirmatory hallmark of otitis externa, commonly called swimmer's ear. The condition is typically caused by bacterial pathogens such as Pseudomonas aeruginosa or Staphylococcus aureus. Inflammation leads to redness, swelling, and tenderness of the ear canal, but the presence of purulent and often malodorous otorrhea indicates active bacterial overgrowth. Because the tympanic membrane is intact, the infection is localized to the external canal rather than the middle ear. Without timely treatment, the infection may extend to surrounding tissues, leading to cellulitis or even necrotizing otitis externa in immunocompromised clients. Now let us consider why the other options are not correct. A scarred or opaque tympanic membrane, which is option 2, usually results from previous middle ear disease such as chronic otitis media or recurrent perforations, but it does not signify an acute external ear infection. Moving on to option 3, a client's report of diminished hearing acuity may occur with otitis externa, but it is usually due to canal swelling or blockage by drainage. This is nonspecific because hearing loss can also result from cerumen impaction, middle ear effusion, or other causes. Finally, option 4, palpable lymphadenopathy near the ear, may appear with various infections, including dental or upper respiratory sources. Although lymph node enlargement can accompany otitis externa, it is not nearly as diagnostic as foul-smelling drainage. To integrate this into clinical practice, remember that otitis externa typically presents with 3 classic features: pain when manipulating the tragus or auricle, swelling and redness of the canal, and foul-smelling purulent drainage. In contrast, otitis media involves the middle ear and is characterized by bulging of the tympanic membrane, pressure behind it, and more systemic symptoms such as fever. Here is your Stan Coast Pearl. When you think of otitis externa, always recall the triad of tragal tenderness, canal swelling, and purulent drainage. These features help you instantly differentiate it from otitis media, which involves middle ear fluid and tympanic membrane changes. Let us move forward into another important pediatric NCLEX scenario that highlights how developmental anatomy impacts disease risk. Parents bring their 3-year-old child to the pediatric clinic because of frequent ear infections. They share that their 18-year-old teenager rarely experiences such infections, and they want to know why younger children are more prone. The nurse explains, and the question asks, which parental response shows an accurate understanding of why young children are more susceptible to otitis media? Here are the possible choices. The first option is that a child's eustachian tube is shorter and straighter. The second option is that a child's eustachian tube is longer and straighter. The third option is that a child's eustachian tube is shorter and more curved. And the fourth option is that a child's eustachian tube is longer and more curved. The correct answer is option 1, a child's eustachian tube is shorter and straighter. This is correct because in children, the eustachian tube is not only shorter, but also wider and more horizontally aligned compared to adults. This structural design makes it much easier for pathogens from the nasopharynx to migrate into the middle ear. Combined with immature immune defenses and frequent respiratory infections in toddlers, the risk of otitis media is greatly increased. As the child grows, the tube gradually elongates, narrows, and angles downward at about 45 degrees, which improves drainage and decreases the risk of infection. Looking at the distractors, the second option, a child's eustachian tube is longer and straighter, is incorrect because longer tubes are protective. In teenagers and adults, the length and downward slope act as a natural barrier against infection. The third option, a child's eustachian tube is shorter and more curved, is also incorrect because children's tubes are short but straighter, not curved. Curvature develops with age and provides resistance to bacterial spread. Finally, the fourth option, a child's eustachian tube is longer and more curved, describes adult anatomy, where these protective changes lower the incidence of recurrent ear infections. For clinical pearls, always remember that infants and toddlers under 3 years have short, straight, and wide eustachian tubes that allow bacteria and viruses to travel quickly from the throat to the ear. Additional risk factors include bottle feeding while lying flat, secondhand smoke exposure, daycare attendance, and weak immunity. Preventive strategies such as breastfeeding, avoiding bottle propping, and limiting pacifier use can help reduce risk. By adolescence, the anatomical changes of length, narrowing, and angulation make ear infections less common. And here is a Stan Coast Pearl. Use the memory trick. Short and straight makes infection great. It is an easy way to remember that the short, straight tubes of children make infections much more likely. Let us move forward into this next NCLEX-style question with careful attention. A 3-year-old child is being treated with antibiotics for acute otitis media, and the nurse wants to evaluate whether the therapy is working effectively. The question asks, which clinical finding provides the best evidence of antibiotic effectiveness? Here are the possible choices. The first option is that the ear feels less warm to the touch. The second option is that ringing sounds within the ear stop. The third option is that ear drainage becomes thin and watery. And the fourth option is that ear discomfort is relieved. The correct answer is option 4. Ear discomfort is relieved. The reason this is correct is that acute otitis media is defined by pain caused by pressure and inflammation behind the tympanic membrane. Once antibiotics begin to control the infection, inflammation subsides, fluid resolves, and pain diminishes. For children, relief of discomfort also translates into improved sleep, feeding, and play behaviors, all of which signal a return to normal functioning. Therefore, pain relief is the most direct and reliable indicator of therapeutic response. Now let us analyze why the other options are incorrect. Considering the first option, the idea that the ear feels less warm to the touch is not reliable. Acute otitis media occurs in the middle ear cavity, behind the eardrum, so the outer ear will not feel warm. Warmth and tenderness are more consistent with external ear infections like otitis externa or cellulitis, not middle ear disease. Shifting to the second option, ringing in the ears, or tinnitus, is not a common feature of acute otitis media at all. It is usually seen in inner ear conditions such as Ménière's disease, sensorineural hearing loss, or ototoxicity. So evaluating its resolution does not reflect antibiotic success. Looking at the third option, the presence of thin or watery drainage actually signals tympanic membrane rupture, which is a complication rather than a sign of recovery. Persistent otorrhea often indicates ongoing infection or chronic middle ear disease, so this is not a measure of effective antibiotic therapy. From a clinical reasoning perspective, the nurse must always monitor for outcomes that reflect both safety and true therapeutic progress. Effective antibiotics should relieve pain, reduce fever, and improve the child's behavior and feeding patterns. Failure to see improvement within 48 to 72 hours suggests resistant organisms, such as beta-lactamase, producing Haemophilus influenzae, and may require a change in antibiotic therapy. Nurses should also educate parents to recognize red flags like new drainage, worsening irritability, or persistent fever, which may indicate complications. Here is the Stan Coast Pearl to make this memorable. Think of pain relief as the child's signal that the battle is being won inside the middle ear. When discomfort subsides, pressure is normalizing and infection is resolving. On the other hand, new ear drainage or persistent irritability despite antibiotics should alert both the nurse and the parent to possible complications or resistant bacteria. Let us carefully move into this next NCLEX-style scenario, which highlights the importance of distinguishing between middle ear and inner ear involvement. A nurse is evaluating a client with a diagnosed middle ear infection, also called otitis media. During the assessment, the client reports several new symptoms, and the nurse must determine which clinical finding is most concerning as evidence that the infection has extended into the inner ear structures. The possible choices are temporal headaches, a sore throat, nasal congestion, and postural dizziness. The correct answer here is option 4, postural dizziness. This finding is the red flag indicator that the infection has advanced from the middle ear into the labyrinth of the inner ear. The labyrinth includes the cochlea for hearing and the vestibular apparatus for balance. When bacteria or inflammation spread to these structures, a condition called labyrinthitis develops. This interferes with vestibular nerve signaling, leading to vertigo, dizziness, nausea, vomiting, and difficulty maintaining balance. Unlike vague lightheadedness, postural dizziness indicates acute vestibular dysfunction, which directly disrupts postural stability through its connections with the 8th cranial nerve and the cerebellum. Therefore, dizziness is the most specific and advanced sign of infection progression. Looking at the incorrect options, first consider option 1, temporal headaches. While headaches may occur in otitis media due to referred pain, they are nonspecific. A temporal headache could also suggest meningeal irritation if the infection spreads intracranially, but this is not the hallmark feature of inner ear involvement. Moving to option 2, a sore throat, this symptom usually reflects the upper respiratory infection that often precedes otitis media because of the connection between the pharynx and the middle ear via the eustachian tube. However, it does not indicate spread into the inner ear. As for option 3, nasal congestion, this is another nonspecific finding often linked to viral respiratory illness or sinusitis. While it can worsen eustachian tube blockage and predispose to middle ear infection, it does not signify labyrinth involvement. Here are a few clinical pearls to keep in mind for exam success. Middle ear infection, or otitis media, commonly presents with pain, fever, irritability, and a bulging tympanic membrane. In contrast, inner ear infection, or labyrinthitis, produces dizziness, vertigo, nystagmus, nausea, vomiting, and imbalance. If untreated, these infections can extend intracranially, leading to dangerous complications like meningitis, brain abscess, or mastoiditis. A useful NCLEX strategy is to always select the symptom that is most specific to the organ or structure in question. In this case, postural dizziness for the vestibular system. And remember the Stan Coast Pearl. Think of the inner ear as your body's gyroscope. When it gets infected, balance is lost, making vertigo or postural dizziness the key red flag finding. Let us smoothly transition into this next clinical question that centers around pediatric ear surgery. A 4-year-old child has suffered from repeated episodes of otitis media that have not improved with multiple courses of systemic antibiotics. Because of the persistence of these infections, the otolaryngologist has scheduled the child for a myringotomy with possible tympanostomy tube insertion. Now the nurse needs to prepare the parents for the procedure, and the key question becomes, which statement best explains the primary therapeutic purpose of a myringotomy? Here are the options to consider. Option A states that a myringotomy prevents permanent hearing loss. Option B suggests that a myringotomy provides a pathway for drainage. Option C notes that a myringotomy aids in administering medications. Finally, option D proposes that a myringotomy maintains motion of the ear bones. The correct answer is option B, a myringotomy provides a pathway for drainage. This is because a myringotomy is essentially a small surgical incision made into the tympanic membrane, or eardrum, to relieve pressure and allow trapped fluid or pus within the middle ear to escape. In young children, the eustachian tube is shorter and more horizontal, making it less effective at equalizing pressure and clearing secretions. Recurrent otitis media often results when this drainage is blocked. By surgically creating a controlled opening, the fluid can drain, pressure is reduced, pain subsides, and the risk of uncontrolled rupture of the eardrum is avoided. Tympanostomy tubes are often inserted at the same time to keep the opening patent, allowing air to circulate and significantly lowering the frequency of future infections. These tubes eventually fall out naturally, but they provide months of relief and protection. Looking at the incorrect choices, let us begin with option A, which mentions preventing permanent hearing loss. While relief of middle ear effusion may improve hearing and reduce the risk of damage to the ossicles or tympanic membrane, the myringotomy itself does not guarantee protection against permanent hearing loss, especially sensorineural loss. Instead, its goal is infection and pressure management. Moving on to option C, which refers to aiding in administering medications. This is not the main reason for the procedure. Although antibiotic drops may sometimes be used after surgery, systemic antibiotics remain the mainstay of treatment for acute infections. The true therapeutic focus of myringotomy is mechanical drainage, not drug delivery. Finally, option D emphasizes maintaining motion of the ear bones. The ossicles, malleus, incus, and stapes, do function better once the effusion is resolved, but the surgery is not primarily designed to protect their motion. Rather, their function improves secondarily once the infection is controlled. In clinical integration, it is essential to understand that eustachian tube dysfunction creates negative pressure, leading to fluid accumulation and recurrent otitis media. The procedure's main role is to relieve effusion, restore aeration, and prevent spontaneous rupture. From a nursing standpoint, preoperative teaching is vital to set realistic expectations for parents, while postoperative care involves monitoring drainage, preventing infection, and educating caregivers about keeping the ear dry and recognizing signs of complications. And here comes your Stan Coast Pearl. A myringotomy is not about permanently fixing hearing, it is about relieving trapped fluid and breaking the cycle of pain, infection, and pressure that can damage the ear if left untreated. Let us now walk through this next NCLEX-style question carefully, shaping it into a script that flows smoothly for narration. Imagine a 5-year-old child who has just been treated for chronic otitis media and is being discharged after an office procedure. During this procedure, a cotton ball soaked with prescribed topical antibiotic was placed into the child's external ear canal. The parent then asks the nurse what they should do with the cotton ball once they are home. The nurse needs to provide clear discharge instructions. Here are the options to consider. Option A says to leave the cotton ball in place until it becomes fully saturated. Option B instructs to keep the cotton ball placed loosely within the ear canal. Option C suggests soaking the cotton ball in hydrogen peroxide before insertion. And Option D advises removing the cotton ball as soon as it becomes dry. The correct answer is Option B, keep the cotton ball placed loosely within the ear canal. Now let us carefully unpack why this is the best response. A loosely placed cotton ball allows the topical antibiotic to wick out gently, preventing fluid from pooling and ensuring consistent absorption into the ear canal. At the same time, it permits drainage of any infectious exudate, reducing the risk of retained moisture that might otherwise cause bacterial or fungal growth. Loose placement also protects the delicate canal from trauma and avoids pushing the cotton against the tympanic membrane, which could cause pain or delay healing. Parents must understand that the cotton ball should be replaced once it becomes moist, not left until fully saturated, because moisture left too long fosters bacterial growth and maceration. Before inserting a new cotton ball, the outer ear can be gently cleaned with mild soap and water, but never hydrogen peroxide, as it is too harsh. Now let us go through why the other options are incorrect. Option A, which says to leave the cotton ball in place until it is fully saturated, is not safe, because this practice encourages bacterial growth, skin breakdown, and blockage of drainage, all of which can worsen the infection. Option C, which suggests soaking the cotton ball in hydrogen peroxide, is also inappropriate because peroxide is irritating, disrupts normal flora, and increases discomfort. Only the prescribed antibiotic should be used, and the cotton itself should be dry at insertion. Option D, which advises removing the cotton ball as soon as it becomes dry, is not correct because this would interrupt its protective and absorptive role. The cotton should remain in place while it is lightly moist and only then be replaced. To summarize with high-yield pearls for NCLEX, the key principle is that loose placement equals safe drainage, no trauma, and optimal medication absorption. For pediatric safety, never tightly pack the canal, as this risks trauma and tympanic membrane perforation. Parents must be taught to replace the cotton ball once it is moist and to avoid home remedies like peroxide unless specifically ordered. And from an exam strategy perspective, remember that when discharge instructions involve placement versus removal versus modification of a prescribed treatment, the safest option that balances effectiveness, comfort, and infection prevention will always be the correct choice. Now shifting our focus to another essential auditory condition. Imagine a 38-year-old client who presents with progressive bilateral hearing loss and reports difficulty following conversations, especially in group settings. The nurse reviews the client's history for potential contributing factors. Based on the suspected diagnosis of otosclerosis, which finding would the nurse expect to discover in the health history? Here are the options to consider. Option 1 suggests hearing loss beginning in early childhood. Option 2 indicates recurrent high fever upper respiratory infections. Option 3 points to a past surgical removal of tonsils and adenoids. And Option 4 mentions a positive family history of hearing loss with otosclerosis. The correct answer is Option 4, a positive family history of hearing loss with otosclerosis. Let us carefully walk through the reasoning behind this choice. Otosclerosis is a hereditary condition characterized by abnormal bony overgrowth around the stapes bone in the middle ear. This fixation prevents proper transmission of sound vibrations, leading to conductive hearing loss and, in advanced cases, even a mixed conductive sensorineural loss. The condition most commonly manifests in early to middle adulthood, often in the 20s or 30s, and has a strong genetic predisposition. Many clients report one or more relatives with the same diagnosis. Women are more frequently affected, and symptoms may worsen during pregnancy due to hormonal influences. That is why a positive family history is the most expected finding in the health history of clients with suspected otosclerosis. Looking at the other options, childhood hearing loss is usually related to congenital anomalies, recurrent otitis media, or syndromes unrelated to otosclerosis, so Option 1 does not fit. As for Option 2, recurrent febrile respiratory infections are linked with temporary conductive loss from otitis media, but they have no role in otosclerosis, which is strictly due to abnormal bone remodeling. Option 3, a history of tonsil and adenoid removal, is also unrelated since these lymphoid tissues play no part in the disease process of the middle ear ossicles. Here is a high-yield takeaway for your exam memory. Otosclerosis is the most common cause of conductive hearing loss in young and middle-aged adults. On bedside testing, Rinne and Weber tuning fork exams often reveal bone conduction better than air conduction in affected ears. Treatment includes hearing aids or, in definitive cases, a stapedectomy with prosthesis placement to restore sound conduction. And remember, symptoms often worsen during pregnancy due to hormonal influences. A unique clinical pearl that highlights the interplay of physiology and disease progression. There is something exciting I want to give you, something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut. Already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy-to-watch, recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, eBooks, and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail. During comprehensive lecture, this isn't just another review, it's everything you need in one. Please scan the QR code right now, or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes you'll also get. Now, let us turn our attention to an important question on hearing disorders. A 46-year-old client has just completed an audiology evaluation and was informed by the physician that they have a conductive hearing loss. The client seeks clarification and asks the nurse to explain what this condition actually means. The nurse must select the best explanation that describes the underlying pathophysiology of conductive hearing loss. Here are the choices. Option A states that sound waves are unable to effectively reach the inner ear due to an obstruction or defect in the external or middle ear. Option B suggests that the cochlea and inner ear hair cells have lost their ability to convert mechanical energy into electrical impulses. Option C explains that there is irreversible damage to the auditory portion of the 8th cranial nerve, impairing neural signal transmission. And finally, Option D proposes that the brainstem and auditory cortex fail to interpret incoming electrical signals from the cochlea. The correct answer is Option A. Sound waves are unable to effectively reach the inner ear due to an obstruction or defect in the external or middle ear. This explanation is accurate because conductive hearing loss occurs when something disrupts the mechanical transmission of sound waves through the outer ear canal, tympanic membrane, or middle ear ossicles such as the malleus, incus, and stapes. Importantly, the inner ear and neural pathways remain intact, but the sound simply cannot reach them efficiently. Common culprits include impacted earwax, otitis media with fluid buildup, tympanic membrane perforation, or otosclerosis, which is the abnormal bony fixation of the stapes at the oval window. A clinical clue often seen is that clients report hearing better in noisy environments due to bone conduction compensation, and tuning fork tests reveal air conduction less than bone conduction, producing a negative Rhine test. The good news for NCLEX is that most cases are treatable, sometimes with simple procedures like wax removal, or more advanced surgeries such as tympanoplasty or stapedectomy. On the other hand, Option B is incorrect because it describes sensorineural hearing loss, where the problem lies in the cochlea's hair cells failing to generate electrical impulses. Causes include chronic noise exposure, ototoxic medications like aminoglycosides, or age-related hearing loss known as presbycusis. This type of loss is usually permanent and managed with hearing aids or cochlear implants, not by correcting a mechanical blockage. Option C is also incorrect as it points to damage of cranial nerve 8, the vestibulocochlear nerve. While this too produces hearing impairment, it is a form of sensorineural loss caused by tumors such as acoustic neuromas or trauma, and it cannot be bypassed through bone conduction. Option D is not correct either since it refers to central hearing loss, a much less common condition where the brainstem or auditory cortex fails to process sound correctly, usually due to stroke, tumor, or brain injury. This is not the same as a conductive problem, which lies much earlier in the hearing pathway. To lock this into memory, remember these high-yield pearls. Conductive hearing loss always involves the external or middle ear and is often reversible. Sensorineural hearing loss involves the inner ear or nerve and is often irreversible. In Weber and Rinne tuning fork tests, conductive loss shows bone conduction greater than air conduction and lateralizes to the affected ear, whereas sensorineural loss maintains air conduction greater than bone conduction but lateralizes to the unaffected ear. Stand coast. Pearl. Think of conductive hearing loss as a locked door before the party. Sound waves cannot even enter the house. Sensorineural hearing loss, in contrast, is when the music is playing inside but the wires are cut, so the brain never gets the sound. Now moving forward, here is another thought-provoking scenario for your NCLEX practice. A nurse leader is guiding the admitting nurse in developing an individualized care plan for a newly admitted client diagnosed with risk for impaired verbal communication related to hearing loss. The key question is, which of the following client-centered goals best correlates with the nursing diagnosis and ensures measurable improvement in communication? Here are the possible choices. First, the client will respond appropriately to communication by staff. Second, the staff will improve verbal communication techniques. Third, the client will demonstrate the ability to express emotions. And fourth, the client will be able to communicate basic needs. The correct answer is option 1. The client will respond appropriately to communication by staff. This is the most accurate because nursing goals must always be client-centered, measurable, and outcome-oriented. In clients with hearing loss, the main problem is receiving and processing spoken messages. By ensuring the client responds appropriately, the nurse can verify that communication strategies such as speaking slowly, maintaining eye contact, using visual aids, and confirming understanding are effective. This aligns directly with the NANDA framework and the SMART format, ensuring goals are specific, measurable, attainable, realistic, and time-bound. Looking at the other options helps sharpen our reasoning. Option 2, the staff will improve verbal communication techniques, is incorrect because this describes an intervention, not a client outcome. It belongs in the nursing actions section of a care plan, not in the goals section. Option 3, the client will demonstrate the ability to express emotions, is also incorrect because hearing impairment does not primarily affect a client's ability to express feelings. The barrier lies in receiving communication, not in emotional expression. Option 4, the client will be able to communicate basic needs, seems reasonable but falls short because it is too vague and could rely on nonverbal methods such as gestures or writing. That does not confirm improvement in verbal communication, which is the core issue of this diagnosis. Clinically, this question highlights a few high-yield pearls. Goals must always reflect what the client will achieve, not what the nurse will do. Hearing impairment creates significant risks for social isolation, frustration, and even safety issues such as missing alarms or instructions. The best practice is to combine assistive devices like hearing aids with strategies such as clear speech, written communication, and visual cues to enhance understanding. Stand coast. Pearl, remember that in care planning, interventions describe nurse actions, while goals must always reflect client outcomes. If the sentence begins with the staff or the nurse, it is not a true goal statement. Let us now move into this next NCLEX-style scenario that highlights the importance of therapeutic communication. Imagine a nurse assisting the team leader in designing interventions for a hospitalized client who has bilateral sensorineural hearing loss and frequently shows frustration during conversations with staff. The central question is, which communication strategy is the most effective to include in the care plan to enhance understanding and reduce misinterpretation? Here are the options to consider. The first option is to speak directly into the client's ear to amplify sound. The second option is to face the client directly and maintain eye contact while speaking. The third option is to drop your voice at the end of each sentence to signal closure. And the fourth option is to raise the pitch of your voice 1 octave higher to increase clarity. The correct answer is option 2, face the client directly and maintain eye contact while speaking. This intervention is most effective because clients with hearing impairment often depend on lip reading or what is called speech reading. This technique does not only involve watching the movement of the lips, but also interpreting facial expressions, gestures, and body language. By facing the client, the nurse ensures that all these cues are visible, making the conversation easier to follow and reducing misinterpretation. Eye contact also demonstrates respect, builds rapport, and allows the nurse to assess comprehension. Evidence-based practice further shows that a steady, slightly lower-pitched, normal-paced voice combined with visibility is the best way to communicate with clients who have sensorineural hearing loss. Now, let us take a closer look at why the other options are incorrect. Beginning with option 1, speaking directly into the client's ear may seem helpful, but it can actually distort sound, especially if the client wears a hearing aid. Instead of improving clarity, it can cause muffled sounds or even discomfort. It also prevents the client from observing visual cues and may feel invasive, which diminishes the therapeutic relationship. Next, considering option 3, dropping your voice at the end of each sentence may unintentionally make the words harder to hear. Clients with sensorineural hearing loss already struggle with clarity, and lowering the intensity of sound at key moments can cause them to miss important information. Consistent tone and volume are much more effective. Finally, looking at option 4, raising the pitch of your voice by an octave often makes words less clear. Sensorineural hearing loss typically affects high-frequency sounds first, so making the voice higher-pitched actually worsens comprehension. It may also make speech sound shrill or distorted through hearing aids, leading to further frustration. To integrate this clinically, remember that sensorineural hearing loss occurs due to damage in the inner ear or auditory nerve, and these clients usually hear low-frequency sounds better than high-frequency ones. Effective communication requires combining visual, auditory, and contextual strategies, such as gestures, writing keywords when needed, and confirming understanding. From a safety perspective, miscommunication could lead to medication errors, missed instructions, or poor adherence to treatment. So optimizing clarity becomes a critical nursing priority. Here is the Stand-Coast Pearl to lock this in. Clients with sensorineural hearing loss typically struggle more with clarity than with volume. Facing them directly, maintaining eye contact, and using a steady, slightly lower pitch is the key to bridging the gap, far more effective than shouting, raising pitch, or speaking into the ear. To continue sharpening your NCLEX preparation, imagine this next situation. A client is scheduled for a stapedectomy due to otosclerosis, but does not seem to comprehend the verbal explanations provided by the physician about the surgical procedure. As the nurse, which intervention is the best alternative to ensure the client understands the details of the procedure at this time? Here are the options. The first option is to provide the client with a printed pamphlet about the procedure. The second option is to ask another client who has undergone a stapedectomy to speak with this client. The third option is to provide a healthcare provider who is proficient in sign language. And the fourth option is to write down all the information in longhand for the client to read. The correct answer is option 1, provide the client with a printed pamphlet about the procedure. This choice is most effective because the client has already received verbal teaching but struggles to fully understand it. Written material offers a structured, standardized, and evidence-based reference that the client can review repeatedly at their own pace. Pamphlets also reduce misinterpretation, support family involvement, and ensure the client receives consistent instructions about crucial post-operative restrictions, such as avoiding nose blowing, heavy lifting, or sudden head movements that could dislodge the prosthesis. Now, let us look at why the other options are less suitable. Asking another client who has undergone the surgery may provide emotional comfort, but peer stories are not reliable for accurate medical teaching, and professional staff remain responsible for ensuring comprehension. Providing a sign language interpreter is only appropriate if the client has profound deafness or routinely uses sign language, which is usually not the case in otosclerosis, where hearing loss is conductive rather than total. Writing all the information in longhand is inefficient, time-consuming, and potentially overwhelming, whereas a standardized pamphlet is concise and user-friendly. A clinical pearl to remember here is that a stapedectomy involves replacing the stapes bone with a prosthesis to restore sound conduction. Because the surgery is delicate, clear postoperative education is essential, and standardized written materials remain the safest way to reinforce learning. For NCLEX success, always remember that when verbal teaching fails, the safest and most effective alternative is to use structured, accurate, repeatable, written educational resources. Let us now move into this important therapeutic communication question, which often shows up in NCLEX-style exams. Imagine a client scheduled for a stapedectomy expresses significant anxiety and says to the nurse, "There are so many awful complications that can happen with this surgery." The nurse must choose the most therapeutic response in this situation. Here are the options to consider. The first option is, you have the best surgeon on the staff. The second option is, tell me more about how you're feeling. The third option is, do not worry. Those things hardly ever happen. And the fourth option is, let us think positively about the outcome. The correct answer here is option 2. Tell me more about how you're feeling. This is the most therapeutic because it invites the client to openly share their concerns. By exploring feelings, the nurse validates the client's fears and establishes trust. Anxiety before surgery is very common, and allowing the client to express emotions gives the nurse a chance to assess the depth of worry, correct any misconceptions, and offer coping strategies. According to NCLEX psychosocial integrity principles, acknowledging and exploring emotions takes priority over reassurance or subject changes. Now let us carefully analyze the other responses. Option 1, which is telling the client you have the best surgeon on the staff, may sound reassuring but is actually non-therapeutic. It shifts the focus to defending the surgeon rather than addressing the client's fears. In therapeutic communication, the nurse must remain client-centered, not provider-centered. Moving on to option 3, do not worry. Those things hardly ever happen. This represents false reassurance. While the intention may be to comfort, it invalidates the client's feelings and discourages further discussion. In NCLEX terms, false reassurance is always non-therapeutic because it blocks communication and leaves the client feeling misunderstood. Finally, option 4, let us think positively about the outcome, is also non-therapeutic because it changes the subject and redirects attention away from the expressed fear. Although positive reframing can be useful later in client teaching or coping reinforcement, the first step must always be active listening and emotional validation. Here is the key clinical insight, or what we call the Stan Coast Pearl. Therapeutic communication always starts with active listening and encouraging the client to share feelings. In NCLEX communication questions, you can usually eliminate choices that provide false reassurance, defend others, or change the subject. By addressing the client's anxiety directly, you not only support psychosocial integrity, but also improve emotional stability before surgery, which can enhance recovery outcomes. Final takeaway. The nurse demonstrates the most therapeutic approach by inviting the client to express feelings, which validates concerns, fosters trust, and opens the door to accurate teaching and emotional support. Let us move into the next carefully designed NCLEX-style scenario that highlights both surgical complications and cranial nerve assessment. A nurse is caring for a client on the first postoperative day after a stapedectomy. Because this surgery places the adjacent facial nerve at risk of injury, which assessment finding would be the most appropriate technique to evaluate the integrity of the client's facial nerve function? Here are the options to consider. Option 1 is asking the client to identify familiar odors. Option 2 is asking the client to smile or raise the eyebrows. Option 3 is asking the client to protrude the tongue midline. And option 4 is asking the client to read printed text from a card. The correct answer is option 2, asking the client to smile or raise the eyebrows. This is because the facial nerve, which is cranial nerve 7, controls the motor functions of facial expressions. During a stapedectomy, which is performed to treat conductive hearing loss from otosclerosis, the proximity of the surgical site to the facial nerve places the client at risk of nerve trauma. Postoperatively, evaluating the ability to smile, raise the eyebrows, close the eyes tightly, or puff the cheeks gives the nurse immediate feedback on nerve integrity. If asymmetry, drooping, or weakness is observed, it signals possible injury that must be reported promptly to prevent permanent paralysis. Now, let us consider why the other options are incorrect. Option 1, identifying familiar odors, actually tests the olfactory nerve, cranial nerve 1. This nerve is responsible for smell, not facial motor function, and it is unrelated to ear surgery complications. Moving to option 3, protruding the tongue midline assesses the hypoglossal nerve, cranial nerve 12. While useful in neurosurgical or stroke clients, it does not reflect risk from middle ear surgery. Finally, option 4, reading printed text from a card evaluates the optic nerve, cranial nerve 2, which controls visual acuity. Although critical in neurologic exams, it is not the priority concern following a stapedectomy. Clinically, nurses must remember that postoperative care after stapedectomy includes not only protecting hearing outcomes, but also preventing facial nerve complications. Additional key care measures include instructing the client to avoid sneezing, blowing the nose, or straining, as these can increase middle ear pressure. The nurse should also position the client on the non-operative side and monitor for vertigo, drainage, or changes in hearing. From a test-taking perspective, the NCLEX strategy here is straightforward. When a question mentions facial nerve integrity after ear surgery, immediately link it with cranial nerve 7 and the ability to move the face, not functions like smelling, reading, or tongue movement. And here comes your stand coast pearl. Ear surgery near the stapes means the facial nerve is at risk. Always ask the face to move, not the tongue to stick out or the nose to smell. Now, shifting our focus to ear surgery recovery. Imagine this scenario. A nurse is providing immediate post-operative care for a client following a stapedectomy to correct otosclerosis. The surgeon has just placed a prosthetic stapes, and the nurse must carefully consider positioning to promote healing and reduce complications. The question is, which position should the nurse maintain for the first 24 hours after surgery to protect the operative ear and reduce the risk of post-operative vertigo? Here are the possible options. First, flat in bed with the head slightly elevated and turned toward the non-operative ear. Second, facing forward in a semi-Fowler's position with knees flexed for comfort. Third, supine with the head of bed elevated and the head resting flat on the occiput. And finally, prone with the head positioned toward the operated side. The correct answer is option 1, flat in bed with the head slightly elevated and turned toward the non-operative ear. Let me explain why this is the right choice. A stapedectomy is performed to replace an immobilized stapes bone with a prosthesis, so that sound can once again be conducted through the middle ear. Because of the close proximity of the cochlea, vestibule, and facial nerve, clients are at risk for vertigo, nausea, vomiting, and prosthesis displacement in the first hours after surgery. Proper positioning is therefore essential. Keeping the client flat with a slight elevation and turning the head toward the non-operative ear has 3 advantages. It prevents pressure on the operative ear, it reduces vestibular stimulation that could worsen vertigo, and it decreases venous congestion to limit edema in the middle ear. This position is evidence-based and safest within the first 24 hours. Now, let us see why the other options are not correct. Choosing semi-Fowlers with knees flexed may look comfortable, but it does nothing to protect the surgical ear or stabilize the prosthesis. Selecting supine with the head on the occiput allows the head to roll accidentally onto the operated side and increases inner ear pressure, raising the chance of vertigo. And picking prone with the head turned toward the operated ear is the riskiest of all. It puts direct pressure on the surgical site, can cause bleeding or drainage into the middle ear, and may damage the delicate prosthesis or even the facial nerve. Finally, here are some clinical pearls to remember. Clients should avoid lying on the operative ear for weeks after surgery, as well as avoid straining, bending, sneezing with the mouth closed, or flying until cleared by the surgeon. Mild vertigo is expected, but severe vertigo, facial weakness, or new hearing loss signals possible complications and must be reported immediately. Stand coast. Pearl, after a stapedectomy, always position the client with the operative ear facing upward and the non-operative ear down. This simple precaution stabilizes the prosthesis, reduces vertigo, and protects the success of the surgery. As we move forward with our NCLEX practice, let us consider a scenario from the world of ear surgery recovery. The day after undergoing a stapedectomy to correct otosclerosis, a client becomes discouraged and anxious, saying, "My hearing is worse now than it was before surgery." The nurse needs to provide education that reassures the client and sets realistic expectations. Here are the options to think about. First, the hearing loss is temporary and results from edema and packing within the operative ear, which should improve as healing progresses. Second, the hearing loss is temporary and will resolve once the auditory nerve regenerates after surgical manipulation. Third, the hearing loss is temporary and will persist until the client is fitted with a customized hearing aid after recovery. And finally, the hearing loss is temporary and will resolve only after new bone growth stabilizes the prosthetic stapes within the ossicular chain. The correct answer is option 1. The hearing loss is temporary and results from edema and packing within the operative ear, which should improve as healing progresses. Now, let us walk through the expanded rationale together. A stapedectomy is performed to treat otosclerosis, a condition where abnormal bone growth around the stapes prevents sound conduction into the inner ear. During surgery, the diseased stapes is removed and replaced with a prosthesis that attaches to the incus. restoring sound transmission. Because this procedure involves very delicate structures, temporary hearing changes are almost always expected in the immediate postoperative period. Looking first at why option 1 is correct, the most common reason for early postoperative hearing loss is middle ear edema, swelling, and the ear canal packing that surgeons place to protect the site. This muffled hearing is only temporary and gradually improves as the swelling subsides, and the packing is removed in about 1 to 2 weeks. Full improvement usually becomes noticeable over several weeks once the tissues have healed. Reassuring the client about this expected process helps reduce anxiety. Shifting to option 2, we can see why it is incorrect. The auditory or cochlear nerve does not regenerate once damaged, so hearing loss cannot improve through nerve healing. This option presents a false explanation and would mislead the client. Next, considering option 3, it is also incorrect, because stapedectomy is designed to restore natural hearing without the need for hearing aids. Suggesting that a hearing aid will be required undermines the purpose of the surgery and would create unnecessary worry. Finally, let us examine option 4. This too is inaccurate because the prosthesis is stabilized immediately during surgery by being attached to the incus. It does not require new bone growth to hold it in place, unlike a fracture that depends on callus formation. Suggesting otherwise would falsely extend the expected recovery timeline. Before we close, here are some clinical pearls to keep in mind. Temporary hearing loss, mild vertigo, tinnitus, and ear fullness are all normal after stapedectomy. Safety is essential, so clients should avoid sneezing with the mouth closed, coughing forcefully, bending, or lifting heavy objects, as these can increase ear pressure and dislodge the prosthesis. Positioning is also important. The client is usually kept flat in bed with the head slightly elevated and turned toward the non-operative side for the first 24 hours to reduce vertigo and protect the surgical ear. Most importantly, hearing improvement typically begins once the packing is removed and progresses over the following weeks. Here is your Stan Coast Pearl. Early hearing loss. After a stapedectomy does not mean the surgery has failed. Instead, it reflects temporary edema and protective packing. The true success of the procedure becomes evident only after healing, when the prosthesis allows sound to travel smoothly through the middle ear again. Let us move forward into another important clinical teaching scenario that often appears on the NCLEX. Imagine a client on the first postoperative day after undergoing a stapedectomy for treatment of otosclerosis. The nurse is reinforcing discharge instructions, and the question asks, which client statement, if made, demonstrates the most effective understanding of how to prevent dislodgement of the internal prosthesis during episodes of increased middle ear pressure? Here are the options for you to consider. Option A says, I will chew food with my mouth closed so I do not disturb the ear canal. Option B says, I will gently blow my nose into a tissue if I feel congestion. Option C says, I will keep my mouth open wide if I have to sneeze. And option D says, I will turn my head to the side whenever I cough. The correct answer here is option C. I will keep my mouth open wide if I have to sneeze. Now, let us carefully walk through the expanded rationale. A stapedectomy is performed to treat otosclerosis by removing the fixed stapes bone and inserting a prosthesis that restores the transmission of sound vibrations through the ossicular chain. In the immediate postoperative period, the prosthesis is delicate and vulnerable to dislodgement. Any activity that sharply increases pressure in the middle ear, such as sneezing, nose blowing, coughing, or straining, can transmit force through the eustachian tube and wrist displacement. This is exactly why option C is correct. By keeping the mouth wide open when sneezing, the client allows the pressure to escape through both the oral and nasal passages. This technique equalizes and dissipates pressure, reducing the chance of a dangerous surge of force being directed into the middle ear and onto the prosthesis. It is a simple but highly protective maneuver that nurses must emphasize during discharge teaching. On the other hand, option A, chewing food with the mouth closed, is incorrect because chewing habits have no effect on middle ear pressure or prosthesis stability. It is simply a matter of etiquette, not a protective strategy. Moving to option B, blowing the nose into a tissue, even gently, creates high nasopharyngeal and middle ear pressures. This action is strongly discouraged after stapedectomy because it could easily dislodge the prosthesis. Finally, option D, turning the head to the side when coughing, is incorrect because it may reduce droplet spread for infection control, but it does nothing to lower the internal pressure transmitted into the middle ear. Coughing should be minimized. and if persistent, medications may be used to reduce the strain. To reinforce clinical practice, clients should also be instructed to avoid Valsalva maneuvers such as straining during bowel movements, lifting heavy objects, or bending forward. They should promptly report any sudden hearing loss, dizziness, facial weakness, or unusual drainage, as these could be signs of prosthesis displacement or complications. Importantly, the first 2 to 3 weeks are the most critical healing period, and precautions must be followed strictly to protect surgical outcomes. And here is your Stancoast Pearl. After stapedectomy, every sneeze counts. Keep the mouth wide open to release pressure and protect the delicate new prosthesis. Let us now move into another important NCLEX-style question that highlights safety priorities after ear surgery. A nurse is providing post-operative care to a client who has undergone a stapedectomy for treatment of otosclerosis. During interdisciplinary rounds, the nurse advises other staff members that the client is at increased risk for injury due to which potential post-operative complication. Here are the options for consideration: fatigue, diplopia, vertigo, and pain. The correct answer is option 3, vertigo. Vertigo is a hallmark complication following stapedectomy because the delicate vestibular apparatus in the inner ear is often disturbed during the surgical process. This disturbance can result from transient paralymph leakage, labyrinthitis, or direct trauma to balance structures. Vertigo is not just lightheadedness. It is a spinning sensation that makes clients highly vulnerable to falls and injuries. Because of this, nurses must implement strict safety precautions, such as keeping side rails raised, assisting with ambulation, and instructing the client to avoid sudden head movements, forceful sneezing with a closed mouth, or lifting heavy objects that might increase middle ear pressure and worsen vertigo. Turning to option 1, fatigue. While it is true that all clients may feel tired following surgery or anesthesia, this is not a unique complication of stapedectomy and does not pose the same immediate injury risk as vertigo. Looking at option 2, diplopia, or double vision, this condition results from cranial nerve dysfunction affecting ocular movements and is not related to inner ear surgery. Finally, considering option 4, pain, mild discomfort at the surgical site is expected, but is typically well controlled with analgesics and does not significantly impair mobility or directly increase the risk of falls. Here is the Stancoast Pearl. After any inner ear surgery, the most important nursing consideration is balance and equilibrium. Always think about vertigo, fall prevention, and injury risk before worrying about less dangerous issues like mild discomfort or fatigue. Exam tip: if the NCLEX question involves a stapedectomy, prioritize vertigo as the most significant post-operative complication requiring immediate safety measures. All right, let us flow smoothly into the next NCLEX-style question, crafted for clear narration. A nurse is providing discharge education to a client who has recently undergone a stapedectomy for treatment of otosclerosis. During this session, the nurse highlights the importance of activity restrictions to protect the delicate inner ear structures while they heal. The key question is, which activity, if performed within the next 6 months, would place the client at the greatest risk for post-operative complications? Here are the options to consider: listening to music, flying in an airplane, driving an automobile, or singing in the choir. The correct answer is option 2, flying in an airplane. A stapedectomy is a microsurgical procedure that involves removing the immobile stapes bone, caused by otosclerosis, and replacing it with a prosthesis to restore normal hearing. Because the prosthesis is extremely delicate in the early healing phase, maintaining stable middle ear pressure is critical. Flying in an airplane is dangerous at this stage because the rapid changes in atmospheric pressure during takeoff and landing can create barometric stress. This can dislodge the prosthetic stapes implant, cause leakage of inner ear fluid called paralymph, trigger vertigo, or even lead to permanent sensorineural hearing loss. For the same reason, scuba diving is also prohibited until an otolaryngologist confirms complete healing. Looking at the other options, listening to music is generally safe since it does not influence barometric pressure or directly impact healing. The only advice would be to avoid excessively loud sounds. Driving an automobile is also safe unless the client develops significant vertigo, in which case driving may be temporarily unsafe. Singing in the choir, particularly gentle singing, does not produce harmful pressure changes. However, clients should avoid straining, forceful projection, or Valsalva-like maneuvers in the immediate postoperative phase. From a nursing perspective, discharge education must also stress other important precautions. Avoid sneezing with the mouth closed, refrain from nose blowing, and avoid heavy lifting or straining, since all these increase middle ear pressure and can threaten surgical success. Clients should also know to report sudden hearing loss, new or worsening vertigo, or fluid leakage from the ear canal right away. Additionally, reinforcing fall precautions is vital, as vertigo is one of the most common short-term complications. Here is a stand coast pearl. After stapedectomy, the greatest enemy is pressure change, whether from flying, scuba diving, or forceful sneezing. Protect the healing prosthesis by avoiding barometric stress for at least 6 months. All right, future nurses, let us smoothly transition into another high-yield NCLEX practice scenario that highlights an important surgical teaching point. A nurse is providing discharge teaching to a client who has undergone a stapedectomy for the treatment of otosclerosis. The key question is, which postoperative condition should the client be instructed to report immediately to the physician, since it poses the greatest risk to surgical outcomes and hearing preservation? Here are the options to consider. Option 1, the onset of a common cold with nasal congestion. Option 2, a sore throat with mild discomfort. Option 3, a productive cough producing sputum. And option 4, conjunctivitis with eye redness and tearing. The correct answer is option 1, the onset of a common cold with nasal congestion. Now, let me walk you through the reasoning. A stapedectomy is a delicate microsurgical procedure where the fixed stapes bone in the middle ear is removed and replaced with a prosthesis to restore sound conduction. Because of the fine precision required, healing after surgery is extremely vulnerable to disturbances caused by pressure changes or infections. A seemingly harmless cold is actually very dangerous in this context, as congestion leads to eustachian tube blockage, middle ear pressure, and sneezing or nose blowing that can easily dislodge the prosthesis or disturb the graft. Even mild viral infections can lead to complications such as otitis media, vertigo, or sensorineural hearing loss. That is why clients are taught to notify their surgeon immediately if they develop cold symptoms, and to avoid straining, sneezing forcefully, or blowing their nose during early recovery. Looking at the other options, option 2, a sore throat may cause discomfort but does not directly threaten the surgical site unless it advances into a severe infection. Option 3, a productive cough, can briefly increase intrathoracic and middle ear pressure, but its impact is usually less critical compared to the constant congestion of a cold. Option 4, conjunctivitis, is limited to the eye and does not influence ear healing, though it still requires treatment. Clinically, the nurse must stress strict precautions, avoid upper respiratory infections, prevent pressure changes such as heavy lifting or bending, and report symptoms like drainage, sudden hearing loss, or vertigo right away. Stand coast, pearl. After a stapedectomy, even a simple cold is not simple at all. Congestion equals pressure, and pressure equals risk of prosthesis dislodgement. Clients must be taught to guard their ear as carefully as a fresh surgical wound. Let us dive into another important clinical scenario that highlights the key features of Meniere's disease, a high-yield NCLEX topic. A 52-year-old client is admitted to the hospital with complaints of fluctuating hearing loss and a sensation of fullness in the left ear. The nurse suspects Meniere's disease and must determine which subjective symptom reported by the client would be most characteristic of this disorder and should prompt further focused assessment. Here are the possible options to consider. Option 1, a burning sensation in the ear. Option 2, pressure localized in the ear canal. Option 3, severe episodic vertigo with a spinning sensation. And option 4, constant ear pain. The correct answer is option 3, severe episodic vertigo with a spinning sensation. To fully understand why this is the correct choice, let us first review the pathophysiology. Meniere's disease is a chronic disorder of the inner ear caused by excessive accumulation of endolymphatic fluid in the membranous labyrinth, leading to increased inner ear pressure, also called endolymphatic hydrops. This pressure disrupts both vestibular function, which governs balance, and cochlear function, which governs hearing. Classically, the disorder is defined by a triad: episodic vertigo, fluctuating sensorineural hearing loss, and tinnitus, often accompanied by a sensation of oral fullness. Now, let us carefully examine each option. Beginning with option 1, a burning sensation in the ear. This is incorrect because burning pain is not associated with Meniere's disease. Instead, It is typically seen with otitis externa or cranial nerve neuralgias. Moving to option 2, pressure localized in the ear canal. While some clients do describe fullness or pressure, this is a nonspecific symptom and can occur in many other conditions, such as otitis media or cerumen impaction. Therefore, it is not the defining hallmark feature. Shifting to option 3, severe episodic vertigo with a spinning sensation. This is correct, as vertigo is the most disabling and characteristic symptom of Meniere's disease. Unlike simple dizziness, vertigo in this context is a true spinning or whirling sensation that can last minutes to hours and may cause nausea, vomiting, and imbalance. Finally, option 4, constant ear pain. This is incorrect because pain is not typically part of Meniere's disease, and persistent ear pain is more suggestive of middle or outer ear infections. From a nursing perspective, the clinical application here is vital. Clients experiencing vertigo are at high risk for falls, so safety must be prioritized. Nurses should assist with ambulation, provide a calm and dimly lit environment, and advise clients to avoid sudden head movements. Dietary measures such as a low-sodium diet, as well as limiting caffeine and alcohol, can reduce episodes. Pharmacologic therapies like meclizine, benzodiazepines, or diuretics may help manage symptoms, and severe cases may eventually require surgical intervention. Here is a high-yield NCLEX pearl to lock this in. Remember the vertigo triad for Meniere's disease: vertigo, hearing loss, and tinnitus, with a sensation of fullness as an additional feature. Always think safety first, because vertigo is not only disabling, but also increases the risk of falls and injury. Let us smoothly move into the next question, which highlights vestibular diagnostic procedures in nursing practice. A 48-year-old client is being evaluated for recurrent episodes of dizziness, imbalance, and suspected vestibular dysfunction. The physician prescribes a caloric test as part of the diagnostic workup, and the nurse is preparing to teach the client about the procedure. The key question is, which explanation by the nurse is most accurate and best prepares the client for what to expect? Here are the options to consider. Option 1, cold and warm water will be instilled into each ear, and eye movements will be observed. Option 2, you will wear earphones through which sound waves are transmitted to assess hearing. Option 3, the lights will be dimmed and electrodes will be attached to the scalp to measure brain activity. Option 4, a blood sample will be taken from your vein and examined under a microscope. The correct answer is option 1, cold and warm water will be instilled into each ear, and eye movements will be observed. This explanation best prepares the client for the actual experience of the test. The caloric stimulation test evaluates the vestibulo-ocular reflex and the function of cranial nerve 8, the vestibulocochlear nerve. During this test, warm and cold water, or sometimes air, is instilled separately into the ear canal, creating a temperature gradient within the semicircular canals. This alters the density and flow of endolymph fluid, tricking the vestibular system into thinking the head is moving. As a result, nystagmus, or involuntary rhythmic eye movement, is observed. A classic memory trick is COWS, which stands for cold opposite, warm same, referring to the direction of the fast phase of nystagmus. For example, cold water in the right ear produces left-beating nystagmus, while warm water in the right ear produces right-beating nystagmus. Now, let us explore why the other options are not correct. Option 2, which describes earphones transmitting sound waves, refers to audiometric testing, a procedure for evaluating hearing but not vestibular function. Option 3, involving dimmed lights and scalp electrodes, points to electroencephalography or electrostagmography. Although ENG may be performed alongside caloric testing, it is not the fundamental explanation of what the client should expect. Option 4, which suggests a blood test, has no relevance to vestibular assessment and is purely for systemic evaluations. In terms of clinical application, clients should be prepared for dizziness, vertigo, or even nausea during the procedure, and nurses must reassure them that these sensations are expected. If anastagmus is absent or reduced, it may signal vestibular nerve dysfunction or brainstem lesions. Additionally, this test is contraindicated in clients with a perforated tympanic membrane or acute otitis media, as water installation can worsen infection. Finally, here is your Stan Coast pearl. Think of caloric testing as tricking the inner ear into believing the head is moving. The eyes reveal whether the vestibular system and brain are functioning properly. Let us continue our journey with another clinically significant question that will sharpen your NCLEX test-taking strategy. During diagnostic evaluation, a client with a history of recurrent vertigo, tinnitus, and fluctuating sensorineural hearing loss undergoes a caloric stimulation test to assess vestibular function. The nurse irrigates the ear canal alternately with warm and cold water while monitoring eye movements and symptom response. The key question is, which finding would the nurse most likely observe in a client with Meniere's disease? Here are the options to consider. Option 1, onset of severe vertigo, nausea, vomiting, and tinnitus. Option 2, no nystagmus or change in symptoms. Option 3, brief nystagmus accompanied by mild dizziness. Option 4, aphasia and loss of consciousness. The correct answer is Option 1, onset of severe vertigo, nausea, vomiting, and tinnitus. This is because the caloric test stimulates the vestibular apparatus by altering endolymph currents with temperature changes. In Meniere's disease, endolymphatic hydrops makes the vestibular system hypersensitive, producing exaggerated responses. Therefore, the client experiences sudden severe vertigo with accompanying nausea, vomiting, and tinnitus, which align with the classic pathophysiology of Meniere's disease. Moving to the next explanation, option 2 is not correct because an absence of nystagmus or response indicates vestibular hypofunction, such as with acoustic neuroma or advanced vestibular damage, rather than hypersensitivity. Shifting to option 3, this is also incorrect since mild nystagmus and dizziness is the expected normal finding in a healthy client. The classic cow's mnemonic, cold opposite, warm same, applies here, but it does not explain the extreme reactions seen in Meniere's disease. Finally, option 4 is incorrect because aphasia and loss of consciousness reflect cortical neurological dysfunction such as stroke or seizure, not vestibular system hyperstimulation. The caloric test only activates vestibular and brainstem pathways, not higher cortical centers. Here are some clinical pearls to seal this concept in your NCLEX preparation. Remember that Meniere's disease means endolymphatic hydrops, creating a hypersensitive vestibular system that overreacts to standard testing. In contrast, vestibular schwannoma, or total vestibular loss, shows no response, and a normal ear demonstrates only mild dizziness with nystagmus. For exam strategy, always choose the most exaggerated response when Meniere's disease is part of the question stem. From a nursing safety perspective, ensure that the client is lying safely, an emesis basin is readily available, and reassurance is provided during this test, since symptoms can be distressing. All right, future nurses, let us dive into another high-yield NCLEX scenario that blends pathophysiology, psychosocial care, and safety priorities. A client recently diagnosed with Meniere's disease appears visibly anxious whenever the nursing staff enter the room. The nurse suspects that the client's anxiety is caused by the fear that nursing care activities may trigger vertigo, tinnitus, or nausea. The question is, which nursing intervention is most appropriate to include in the care plan at this time? Here are the options to carefully consider. Option 1 is to allow the client to suggest preferred ways for nursing care to be performed. Option 2 is to discontinue nursing care measures temporarily until anxiety decreases. Option 3 is to restrict nursing care to only nutrition and elimination needs. And option 4 is to perform all nursing activities as quickly and efficiently as possible. The correct answer is option 1, allow the client to suggest preferred ways for nursing care to be performed. This option is correct because it emphasizes therapeutic and client-centered care. In Meniere's disease, sudden movements, loud noises, or bright lighting can trigger vertigo and nausea. By inviting the client to guide the pace and method of care, the nurse supports autonomy, reduces anticipatory anxiety, and builds trust. For example, the client may request dimmed lights, slower repositioning, or explanations before each intervention. This approach preserves the client's sense of control, which is often the key factor in decreasing vertigo-related distress. Turning now to why option 2 is not correct. Discontinuing nursing care altogether may temporarily decrease anxiety, but it compromises essential care. Clients with Meniere's disease still require hygiene, safety monitoring, and medication administration. Neglecting these needs increases risks of dehydration, malnutrition, or falls, and is not consistent with professional nursing standards. Looking at option 3, restricting care to only nutrition and elimination is also incomplete. While dietary adjustments like a low-sodium diet and elimination support are important, holistic care is required. This includes medications such as meclizine or diuretics, fall prevention strategies, and psychosocial support. Narrowing care only to nutrition and elimination disregards the comprehensive nursing role. Finally, let us examine option 4. Performing care quickly may seem efficient, but in this condition, rapid or unexpected movements intensify vertigo, tinnitus, and imbalance. Instead of calming the client, this approach would heighten anxiety and worsen symptoms. Nursing actions in Meniere's disease should always be slow, deliberate, and predictable. Clinically, it is important to remember that Meniere's disease is caused by endolymphatic hydrops, excessive fluid in the inner ear. Clients often experience episodic vertigo, hearing loss, tinnitus, and oral fullness. Nursing care focuses on reducing triggers, maintaining safety, and supporting emotional well-being. Fall precautions, slow communication, and client collaboration are essential. Here is the Stand Coast Pearl. Control reduces anxiety. In Meniere's disease, allow the client to guide care. Slow, predictable, and collaborative nursing actions reduce vertigo triggers and build trust. Let us now move into another essential NCLEX-style practice question, designed to strengthen your understanding of ear disorders. Imagine a client who has just been diagnosed with Meniere's disease and asks the nurse to clarify what the physician meant when explaining the cause of this condition. The nurse needs to provide the most accurate response. Here are the options to consider. Option A states, it is caused by an electrolyte deficiency that alters inner ear conduction. Option B says, it results from an excess of fluid within the inner ear labyrinth. Option C suggests, it develops because of a vitamin deficiency that weakens neural pathways. And finally, option D explains, it occurs due to an anatomic defect of the inner ear structures. The correct answer here is option B. It results from an excess of fluid within the inner ear labyrinth. Meniere's disease is characterized by endolymphatic hydrops, which means there is an excessive buildup of endolymphatic fluid inside the membranous labyrinth. This disrupts the balance between endolymph and paralymph and alters pressure regulation, causing distortion of sensory hair cells in the cochlea and vestibular system. This disturbance produces the classic triad of symptoms: vertigo, tinnitus, and fluctuating sensorineural hearing loss, often accompanied by sensations of fullness in the ear and imbalance. Although the precise cause is still unknown, possible contributing factors include hypersecretion of endolymph, hypoabsorption from poor drainage, defects in membrane permeability, viral infections, autoimmune reactions, allergies, vascular compromise, hormonal fluctuations, and even psychosocial stress. In all cases, the unifying problem remains excessive inner ear fluid interfering with auditory and vestibular function. Now, let us analyze the incorrect choices. Option A, which links the condition to electrolyte deficiency, is inaccurate because while electrolyte imbalances can affect muscle and neurologic function, there is no established connection between sodium, potassium, or other electrolyte disturbances and Meniere's disease. Moving to option C, vitamin deficiency is also incorrect. Although vitamin deficiencies can contribute to neurologic conditions like neuropathy, they do not lead to the fluid dysregulation seen in Meniere's. Lastly, option D, suggesting an anatomic defect, is also wrong. Unlike congenital malformations or structural abnormalities of the ear, clients with Meniere's disease usually have normal anatomy. The issue is fluid balance, not fixed structural damage. From a clinical and NCLEX perspective, it is important to remember that Meniere's disease is a chronic and progressive condition. Nursing care should include lifestyle modifications, such as a low-sodium diet and avoidance of caffeine, nicotine, and alcohol. Medications like diuretics, antihistamines, and vestibular suppressants are commonly used. Safety measures are critical because vertigo can increase the risk of falls. In severe and refractory cases, surgical interventions like endolymphatic sac decompression or labyrinthectomy may be necessary. Most importantly, nurses should provide education about the unpredictable nature of attacks and stress the need for long-term management strategies. Stand Coast. Pearl, always think of Meniere's disease as a flood within the inner ear, not a lack of vitamins, not a structural defect, but an overwhelming buildup of fluid that disrupts balance and hearing signals. Let us smoothly continue with another NCLEX-style question, this time focusing on the care of a client experiencing an acute attack of Meniere's disease. The nurse observes that the client is suffering from vertigo and nausea, and must decide which intervention is most effective in preventing worsening nausea and vomiting. The options include increasing the client's intake of oral fluids, changing the client's position frequently to maintain mobility, keeping the room lights dim and reducing visual stimulation, or avoiding sudden movements and preventing jarring of the bed. The correct answer is option 4, avoid sudden movements and prevent jarring of the bed. This action is the most effective because sudden head or body movements overstimulate the vestibular apparatus, which triggers vertigo, nausea, and vomiting. By maintaining stillness and reducing motion, the nurse minimizes overstimulation of the semicircular canals and vestibular system. This not only decreases symptoms, but also improves client safety, as individuals with vertigo are at high risk for falls during acute episodes. Looking at the first incorrect option, encouraging the client to increase oral fluid intake may sound supportive, but in fact it can make the condition worse. Méniere's disease is characterized by endolymphatic hydrops, an abnormal buildup of inner ear fluid. So additional fluid intake can intensify the imbalance. Long-term management usually involves fluid and sodium restriction, and forcing fluids during an acute episode may actually increase nausea, vomiting, and the risk of dehydration. Turning to the second option, frequent position changes might seem helpful in other conditions to prevent immobility complications. But in this case, movement actually worsens vertigo and nausea. During an acute attack, the safest and most therapeutic approach is to minimize mobility and allow the client to rest quietly, preferably with the head slightly elevated. Mobility should only be encouraged once the acute phase has resolved. Now, considering the third option, keeping the room lights dim and reducing visual stimulation, can indeed provide some comfort by lowering sensory input. While this measure reduces discomfort, it does not directly address the root trigger of the client's symptoms. The vestibular overstimulation caused by sudden movements is the main factor driving vertigo and nausea, so environmental calmness is supportive, but not the most effective primary intervention. Clinically, it is important to remember that Meniere's disease is a chronic inner ear disorder marked by episodic vertigo, tinnitus, fluctuating hearing loss, and a feeling of fullness in the ear. The underlying cause is an abnormal accumulation of endolymphatic fluid within the membranous labyrinth, leading to balance disturbances and severe nausea. During acute attacks, the highest priority is to reduce vestibular stimulation, prevent vomiting, and ensure the client's safety. Here is your Stancoast Pearl. In Meniere's disease, stability is the cornerstone of care. Even small jolts, sudden head turns, or environmental disturbances can unleash a cascade of vertigo and vomiting. The nurse's role is to maintain a steady, calm, and low-stimulus environment that protects the client from complications while symptoms are managed. Let us smoothly transition into this next NCLEX-style question that focuses on client education for Meniere's disease. The scenario is as follows. A client with a confirmed diagnosis of Meniere's disease has responded well to conservative treatment and is preparing for discharge. The nurse is providing discharge teaching and emphasizes lifestyle modifications to prevent recurrence of acute attacks. The critical teaching point is, which dietary restriction should the nurse stress as the most important for long-term symptom control? Here are the options for consideration. Option 1 is restriction of dietary fats. Option 2 is restriction of dietary sodium. Option 3 is restriction of dietary potassium. And option 4 is restriction of dietary cholesterol. The correct answer here is option 2, restriction of dietary sodium. This is because sodium restriction is the single most important dietary intervention for clients with Meniere's disease. Sodium directly influences the body's fluid balance, and when sodium intake is excessive, fluid retention occurs. This leads to increased endolymphatic pressure inside the labyrinth of the inner ear. That extra pressure disrupts the balance between endolymph and paralymph, which worsens vertigo, tinnitus, and hearing fluctuations. By following a low-sodium diet, typically limited to 1,000 to 2,000 milligrams per day depending on severity, clients can successfully reduce inner ear fluid retention and decrease both the frequency and intensity of acute episodes. Research has shown that many clients are able to control Meniere's disease effectively with sodium restriction alongside medications like diuretics, vestibular suppressants, or antihistamines, often avoiding the need for surgery. Nurses play a critical role in teaching about hidden sources of sodium in processed foods, canned soups, fast foods, pickles, and sauces. as these can unknowingly trigger recurrences. Now, let us examine why the other options are incorrect. Beginning with option 1, restriction of dietary fats. This has benefits for cardiovascular health, but it does not alter inner ear fluid balance or vestibular function. Thus, it would not prevent vertigo episodes in Meniere's disease. Moving on to option 3, restriction of dietary potassium. This is not appropriate at all. Potassium is vital for maintaining normal muscle and cardiac function, and it plays no role in the disease mechanism of Meniere's. In fact, clients on diuretics like furosemide or spironolactone need to ensure adequate potassium intake to avoid hypokalemia. Restricting potassium could be harmful. Finally, option 4, restriction of dietary cholesterol, while beneficial for overall cardiovascular health, does not impact inner ear physiology. Meniere's disease is not caused by lipid disorders, so cholesterol reduction has no effect on preventing recurrence. To integrate this into clinical practice, remember that Meniere's disease is defined by episodic vertigo, tinnitus, fluctuating hearing loss, and ear fullness, all linked to excess endolymphatic fluid. Triggers like high sodium intake, caffeine, alcohol, and nicotine can worsen symptoms by altering vascular tone and fluid retention. Nurses should stress label reading, avoiding processed foods, spacing fluid intake evenly, and maintaining hydration while keeping sodium intake restricted. Medication therapy may include diuretics to reduce fluid, vestibular suppressants such as meclizine or diazepam during acute attacks, and antiemetics for nausea. Lifestyle advice should also include avoiding sudden movements, managing stress, and ensuring safety to reduce the risk of falls during vertigo episodes. Here is a Stan Coast pearl to make this stick. Think of it as sodium equals spinning. The more sodium the client consumes, the more spinning or vertigo they will experience. By lowering sodium, the inner ear fluid is stabilized, and dizzy episodes are reduced. Let us now move into another engaging NCLEX-style practice scenario that tests your knowledge about patient education and chronic disease management. The question is as follows. A nurse is providing discharge teaching to a client with a confirmed diagnosis of Meniere's disease. Which statement by the client indicates a need for further teaching? Here are the options to consider. The first option is, I will feel well between attacks. The second option is, future attacks may last minutes or days. The third option is, my hearing will gradually improve. And the fourth option is, Meniere's disease is incurable. The correct answer here is option 3, my hearing will gradually improve. This is incorrect because hearing loss associated with Meniere's disease is progressive and irreversible. The disease results from an excessive buildup of endolymphatic fluid within the inner ear, leading to increased endolymphatic pressure. Over time, repeated episodes of vertigo, tinnitus, and ear fullness cause irreversible damage to the hair cells of the cochlea, resulting in progressive sensorineural hearing loss. Once these delicate cochlear hair cells are destroyed, they cannot regenerate, meaning that hearing recovery is not possible. Therefore, this client's belief reflects a knowledge deficit and indicates a need for further teaching. Shifting attention to the first option, I will feel well between attacks. This statement is actually correct. Clients with Meniere's disease generally experience sudden, unpredictable attacks of vertigo, tinnitus, and hearing changes. However, between these attacks, they usually return to their baseline state of health and are able to carry on with normal daily activities. Recognizing the episodic nature of the condition demonstrates accurate understanding. Looking next at the second option, future attacks may last minutes or days. This is also accurate. The duration of Meniere's episodes can vary widely, sometimes lasting just 20 minutes, but occasionally extending to several hours or even days. This variability is a classic feature of the disease and is important for clients to understand, since it affects safety planning and lifestyle adjustment. Finally, considering the fourth option, Meniere's disease is incurable, this statement is correct as well. While treatment approaches such as sodium restriction, diuretic therapy, vestibular suppressants, and in severe cases, surgical interventions can help reduce the severity and frequency of vertigo episodes, there is no permanent cure. In advanced cases, surgical procedures like vestibular nerve section or labyrinthectomy may control vertigo, but often result in permanent hearing loss. The client's acknowledgement of the chronic, incurable nature of the condition demonstrates realistic expectations. Here are some clinical pearls you should remember for the NCLEX. The classic triad of Meniere's disease is episodic vertigo, fluctuating sensorineural hearing loss, and tinnitus, often accompanied by oral fullness. The disease leads to progressive, irreversible damage to hearing. Nursing teaching should emphasize fall precautions during vertigo episodes, adherence to a low-sodium diet, and lifestyle modifications to reduce symptom severity. In more advanced or refractory cases, intratympanic gentamicin injections or surgical procedures may be considered. NCLEX Insight. This type of question evaluates whether the test taker can distinguish between correct knowledge and an incorrect expectation regarding recovery in a progressive, incurable disease. It highlights the importance of patient teaching, chronic disease progression, and critical elimination of distractors. Thank you. See you in next video.